Well, that's the problem, isn't it, with all psychosomatic disorders, is that basically people are dismissed as you say, as just attention seeking. I say to everybody all the time that, we're all a mess of psychosomatic symptoms at all times. That's how we work. You can tell that somebody is sad by looking at them. You don't have to ask them. You can tell if a person is confident or shy by looking at them. We communicate through our bodies. I think that, our medicalization and biologizing symptoms makes them a permanent feature of a person. So if I say that my dissociative seizures are due to abnormal brain connections, well, that sounds like a pretty permanent thing. I'm not sure I can recover from that. So we are not seeing the world literally as it is. We are taking in the sensory signals, and we are at the same time manipulating those sensory signals to make sense of them according to our experience. And that works brilliantly, 99.9999% of the time. But it also means that our sensory systems are not reliable no matter how hard we're trying.
You have found the Thinking Mind podcast. Hi everyone, welcome back to this week's episode where we're thrilled to welcome Dr. Suzanne O'Sullivan. Dr. O'Sullivan is a consultant neurologist at the National Hospital for Neurology and Neurosurgery in London. She is also the author of 3 award-winning books which look at psychosomatic disorders and neurological disorders. I really wanted to speak to Dr. O'Sullivan because reading these books made a huge difference to the way that I worked with patients during the earlier parts of my training. I read these books during my foundation years and I was working on a stroke rotation, and it really, really helped how I practice medicine, my interactions, and how I thought about my trajectory in medical training as well. I think there's a lot to be learnt, whether you're a medical specialist or whether you are someone who is interested in finding out more about the brain and the body. So I really hope that you enjoy the podcast. It's an epic one because we were so interested in everything that Dr. O'Sullivan was saying. So make a cup of tea, settle in and enjoy. This is the Thinking Mind podcast. Here you can access in-depth conversations all about psychology, psychiatry, psychotherapy and self-development. Hello, Dr. O'Sullivan. I'm very excited to welcome you onto the podcast, and we've got Alex here with us speaking as well. Dr. O'Sullivan, you're a neurologist working in London, and you are the author of 3 books, if I'm not mistaken, which have won multiple prizes and are well recognised as beautiful books that take us through things that you have seen in your work as a neurologist, from general neurological disorders, but also working with functional neurological disorders. So I'm really excited to speak to you today about what functional neurological disorders are, your journey across the world to think about them, and your, I guess, more general ideas about some of the issues in the way that we work in medicine in Western society and what we can learn by looking at how disease and distress is thought about across the world. So welcome.
Thank you.
I guess to start, I might start where some of your books start, which is with quite an honest discussion and quite a frank discussion of what got you interested in neurology in general, but also about your journey to working with functional neurological disorders and the kinds of, I guess, changes in your thinking that you developed through training, in part because I really recognise those in myself as well. So I wonder if you could speak to us about what got you interested in neurology and then how you have come to be writing about these disorders.
Yeah, I mean, neurology, I think like a lot of junior doctors or medical students, I was inspired by individuals who made me interested in a particular topic. I had, when I went into medicine, I didn't go in, it was almost, I think people like to think we enter medicine because we want to help people and, have this kind of altruistic kind of personalities, etc. But, honestly, I went to quite a school where we didn't get a lot of guidance. I studied medicine because it looked like it was going to be difficult, and I wanted to prove I could do it, which is not a very sort of nice thing to admit, but it's true. And therefore, I went into medicine without any real great ideas about what kind of doctor I wanted to be. I was inspired by the neurologists I work with, and I quickly kind of realized that the brain, it presents illness and distress in so many different ways. I mean, I don't want to sort of denigrate anybody else's speciality, but there's a limited number of things that can happen when the heart starts going wrong. I mean, it's an exciting specialty, cardiology, because you get to run down the corridor and pump on people's chests and so forth. You have exciting emergencies. But the brain just produces this incredible array of both abilities and inabilities. And once I kind of saw that, and I worked with people who were just so inspirational, they were so sort of passionate about their own subjects, which is always really sort of inspiring. So I was interested in neurology for that reason, because I love the detective work of it. I love that somebody comes into you and says, I've got a tingling in my toe and my eyelid won't stop twitching, and I'm supposed to put that together. And it's the thought processes of that was really attractive for me. So it was very much a case of I was interested in, the sort of way that you make a clinical diagnosis and the sort of fascinating array of ways that the brain goes wrong and the way that it works brilliantly. I had zero interest in functional disorders. Well, functional disorders didn't exist as a medical specialty when I was training. I qualified in 1991. I had, pretty extensive training in clinical neurology because I did a neurology training scheme and a neurophysiology training scheme. I did a lot of clinical work. And in that time, I never once heard psychosomatic disorders discussed, and therefore I had no particular interest in them. And looking back, I'm quite confused by the whole thing, if I'm being honest. Why don't I remember all those patients that must have come to me with a problem that was functional under a different name at the time? Why don't I remember asking, what are we supposed to do with these people, or where am I supposed to send these people? I just don't remember that. It wasn't considered to be part of our practice. And I, being, I don't know, a stressed out junior doctor, just accepted that, I guess. So my interest really was in epilepsy, and my interest was in the brain when I qualified and became a consultant. What happens when you become a consultant is that you have to take full responsibility for something. And that was when I suddenly started seeing, dissociative seizures, functional seizures, psychosomatic seizures everywhere. In my video telemetry practice, they were 40-50% of the admissions. And that was the first time I realized that if I continued to be disinterested in this area of medicine, I would be doing a lot of just seeing very, very sick, very, very young people and saying, you're not my patient, you can go away, essentially. And I think that a lot of neurologists do that. They say, this isn't within my area of expertise. I'd love to help you, but I can't. Goodbye. I just found that I couldn't do that. And I had to find a way to reconcile myself with this difficult to treat, under-researched medical problem. And that was really where my interest grew. I think it also made a little bit of a difference. I was a young woman, and a lot of my patients were young women. And I was seeing a lot of very young women having hundreds of seizures a month, and I had nowhere to send them. So I started out really just caring about neurology, and then it became a necessity to care about the psychosomatic things. And then they came to ultimately interest me and reward me a great deal more than some of the neurological things I've been interested in the first instance.
And we've used sort of a number of different words as we've talked just now. And you also make the point in your books that language around these disorders gets a bit of a thorny issue, and that maybe it's actually not the issue to get thorny about. But I wonder if we could just to kind of give people a heads up of the kinds of words that we'll be using, what they mean, what we're talking about.
So I'm primarily talking about psychosomatic disorders, by which I mean real physical disabilities. I emphasize the word real because I think when people hear anything psychosomatic, they think that sort of means that the symptom is less real or less disabling. So real physical disabilities, which can be very profound, but which cannot be explained by disease and likely have some sort of psychological cause. So when I was training as a doctor, they were referred to as conversion disorders. So psychological distress being converted into physical symptoms. Later, they were referred to as psychosomatic disorders. Now we use the word functional most often. So functional is a word that implies that the nervous system isn't functioning correctly, but doesn't, as psychosomatic does, suggest that there is a kind of psychological underpinning. I also will use the word dissociative. So most people are familiar with dissociation, which is that feeling of kind of unreality, or yourself or things around you not feeling real, or sometimes for other people, just physical symptoms like dizziness, which can be the sort of underpinning for some psychological or psychosomatic disorders like seizures, for example. So just to kind of, yes, I do have strong feelings about the labeling. I mean, in my many years as a doctor, the seizures I deal with, which used to be called non-epileptic attacks, psychogenic non-epileptic attacks, then dissociative seizures, functional seizures, the name keeps being changed because psychogenic non-epileptic attacks implies something, if partially to the medical community, but certainly to the general public, that it sounds psycho, you sounds like, you're mad, you're doing it, you're crazy, etc. I can see that word is problematic. So we've tried to cleanse these sort of words from the disorder. Hence, we're now calling these seizures functional seizures. I do have an issue with that. I don't agree with that evolution. The reason I don't agree with it is because I think that, the cognitive processes that make up the mind and psychological distress are all absolutely fundamental to the development of these disorders. And if we try to cleanse the disorders of any words that refer to the mind or any words that refer to psychological distress, then I think we are a little bit part of the problem, because we're kind of saying it's not okay to talk about psychology and it's not okay to talk about the mind. It's trying to turn disorders where psychology is incredibly important into purely biological disorders. So I give in a little bit, and I do use the word functional, but I feel like we should just say, let's call everything psychosomatic and teach people that the mind-body interactions are real and uncontrollable, so that we don't have to worry about the name. The name should not be the most important thing. It should be understanding the fundamentals of the fact that you cannot control the mind-body interaction, and that, psychosomatic disorders are things that can affect anyone. They don't apply anything about your personality or how strong you are or how intelligent you are.
You say when we hear the word psycho, there's something about you're mad, you're crazy, and you emphasize the word real in your explanation. And there is this sense that it isn't real, or it's being faked and kind of consciously put on. And this is something that I find really hard to get my head around. And I know, I guess, easier now as I've spent years going through medical training. But certainly at the beginning I did. And so it'd be great if we could spend a bit of time hearing how you think about this kind of distinction between this is not something that is being consciously put on. It is something that involves an unconscious process, but nonetheless, it isn't something that you are at the complete mercy of and can't do anything yourself to change, that you have no power to deal with this condition that is affecting you.
Well, it's obviously of fundamental importance that patients, but everybody, and I think doctors, not doctors working in the field of psychology, but doctors working in the general medical field where these patients are going, need to understand that these are entirely kind of unconsciously generated. And I went through the same, I think all medical students go through this. I went through it, where I saw people in clinic who were completely paralyzed in their legs. I examined them on the couch, and as a neurologist, you can make quite a clear diagnosis of a functional disorder if somebody has completely paralyzed legs, because there should be patterns of muscle weakness and patterns of reflex changes that don't fit with biology. So the diagnosis would be easy, examining someone on a couch. But I would find myself, as I was making my notes, peeping at the patient from the corner of my eye, looking for the moment that they would move when I wasn't looking. And I was doing that because I believed that, that they could move, and I was waiting to sort of catch them out, per se. I wasn't waiting to go, ta-da, I caught you. I was just in my curiosity. I wasn't trying to sort of put a patient in a difficult position. There was somewhere in my brain that I believed that they could move, and I was trying to prove myself right. I mean, when I was watching a patient the corner of my eye, I wasn't, wanting to humiliate them or degrade them in any way. What I was trying to do was I couldn't get my own head around this concept that somebody had the physical ability to move, but they couldn't move. And I was just trying to find evidence for myself that told me that, that explained it. So we've all been through that. And I think it's a natural part of the process in medical students. I now know that these problems are 100% unconsciously generated, and I can see it in the patients that I see. When I see people with really just devastating dissociative or functional seizures, psychosomatic seizures, they come to the clinic and they collapse in front of me. The minute you put EEG leads on the head of a person with dissociative seizures, the frequency with which they have a seizure within moments of starting the test is incredibly telling in itself, because a person who's pretending to be sick or is seeing the expert neurologist or who's having the test that will prove the diagnosis one way or the other, someone who's trying to trick you doesn't have a seizure in that moment. They've got the good sense to have the seizure in the car park outside, and when all the electrical leads are on their head, that's exactly when it won't happen. And yet that's exactly when it always does happen. I can see in the behavior of seizures in someone with dissociative seizures the desperate need for answers and the desperate need for help, and that speaks to me to the unconscious nature of these attacks. And it's so important in discussing it with patients. And I usually will use an example like something like the heart, how the heart responds to kind of emotional things, to help patients to understand how unconscious these things are. Because I will say to patients, well, we've all had the experience that when you're frightened, your heart goes quickly. Now, if I was frightened and my heartbeat went up to 150 beats per minute, you would not say to me, you're doing that on purpose. You would not say to me, stop it, slow it down. You can stop that. You wouldn't believe it to be under my control, and you wouldn't believe that I could just stop it if I wanted to. But you would also understand that I wasn't imagining it. My heart really is racing. But finally, you would understand that although my heart is racing, I don't have a heart disease. And I think those sort of examples for patients are useful to help them to kind of understand how outside of their control these disorders are. And while they're not imagining the symptoms, it doesn't mean that the organ that is producing the symptom is diseased per se. I think a lot of doctors still struggle, though, with this concept that these are definitely outside of the patient's control. So fortunately, we do now have functional MRI studies, etc., that will help us to distinguish. You put somebody in an MRI scanner who's pretending to be paralyzed, and somebody else who has a functional paralysis, and someone else who can move normally, and you will see different patterns of brain activation in those three groups. That pretending to be paralyzed and having a functional paralysis are not the same thing, because what's happening in the brain is not the same. I personally don't need a functional MRI to tell me that. I can see it in the patients who come back and they've had a scan and they absolutely flabbergasted to learn that scan was normal, because they are on a genuine hunt for disease. I don't believe that the behavior displays any sort of conscious awareness of what's happening. But fortunately, we do now have the science to prove that to the doubters.
There's a really interesting piece of history which pertains to this. Freud, I'm curious what your thoughts on Freud are. Freud became convinced of an unconscious psychology that had a lot of power when he watched someone else, Charcot, hypnotize a patient, and the patient had a palsy, a paralysis of her whole arm, which, as you said before, that's unusual. It doesn't fit with a particular neurological disease pattern to have a paralysis of your whole arm. And under hypnosis, that patient then could move their arm. And that gave Freud the understanding that there perhaps is some sort of unconscious psychology operating in normal waking life that could somehow be bypassed under an alternative state of consciousness, such as hypnosis.
Yeah, I mean, I'm no expert in Freud, nor am I extensively well read in Freud, but basically studies in hysteria has many ideas that I would subscribe to. I think that, these conditions are very much about suggestibility. And what is hypnosis about? It's about suggestibility. So, very often these disorders arise out of a very strong belief that someone has about how their body should work. And if you can kind of counter that belief, then why shouldn't they overcome their weakness or their disability of any sort? I don't, when you read studies in hysteria, you kind of get this feeling that, Freud's kind of seminal book on this, you get the feeling that, like, if you can just track symptoms back to their moment of kind of the moment that created them, the moment of trauma, that they will magically melt away. Unfortunately, in my experience, that does not happen. However, I think what we learn from examples like the one that you give is that the suggestibility is very powerful and can make you sick and can make you better very quickly. It's very interesting with dissociative seizures. Actually, I don't practice hypnotism, but what you can do with dissociative seizures, if you see someone at early enough a stage in their journey, and this person could be having loads and loads of seizures, if you discuss the concept of dissociation and how these seizures develop with patients, you can often see the seizures disappear with that one conversation. So it's really incredible how quickly these kind of an idea about how the body works affects how one uses one body and how one responds to certain symptoms to create other symptoms. So I think that the idea, I do wonder sometimes if we shouldn't use things like hypnotism more in these conditions, because I would suggest that they might be helpful for a certain percentage of patients.
We just did an episode all about hypnosis with Dr. David Spiegel, who's an expert from Stanford. And he talks very highly of it. He's worked in it his whole career. He's done many well-regarded studies on it. And he's actually releasing an app called Reverie to allow people to hypnotize themselves if they're hypnotizable for various indications, like stopping smoking, changing one's diet, pain, and things like that.
I think that's amazing. And I think we have to get past hypnotism has quite a negative kind of public kind of persona is the problem. People associate it with either the theatrical side where people make you do stupid things, but also there's been suggestions in the past of, therapists planting ideas during hypnotism, etc. So we have to kind of create a modern version of hypnotism, but I certainly think it would be useful for some people, because these sort of functional psychosomatic disorders, they come from ideas, and they come from ideas about how the body will work, or they come from ideas how one symptom leads to another. And what hypnotism is, it plants another suggestion that the body works differently to that.
One thing that I loved in your books is your explanation of how beliefs can lead to these disorders, and sort of your very clear explanation of how we make predictions about the world and how, when those predictions don't fit or go wrong, things can go wrong. Could you talk about that?
Yeah. I mean, we have expectations of what will happen to our bodies in certain situations. And I often think of my own experience at the beginning of the COVID pandemic, which is that, I was facing potentially doing work that I hadn't done in 2 decades, working in a general ward or doing general medicine. And I was listening to news broadcasts every day that said, this many people died. I was also listening to news broadcasts that said, search your body for all of these things. And if you notice these things, then this could happen. And the context of that, of searching my body intently for sort of signs that I was the next victim, you notice things. And what happens when you notice things is then, oh, I've noticed the first symptom of the thing that I think, that I should be scared of. When you notice the first thing, then all you have to do is search for the second thing. Unfortunately, our bodies are a kind of a mess of noise, much like the external noise. We've got loads of internal bodily noise. So once you sort of notice a bodily change and consider it to be a symptom, you can inadvertently think yourself into the subsequent processes of the disorder. because a good example would be somebody with a needle phobia, about how our bodies can produce symptoms in the absence of an actual stimulus. So if someone has a very, very strong belief that that a needle will hurt intensely and they're terrified of needles, and sometimes when they're getting an injection or a blood test, they feel the pain of the needle before the needle even pierces their skin. Or in similar ways, if we're sat beside somebody on the bus who's got, dirty, and we think they have a contagious sort of, fleas or whatever, you can feel the crawling in your skin when nothing has actually happened to you. So our nervous system, our brains easily sort of overpower us based on our expectations. So if I think I have COVID and then I feel there's a tickle in my throat, my brain is easily able to kind of overpower my neurological system to give me the next symptom and then give me the next symptom. So our predictions of what will happen in a certain circumstance has the power to make us unwell. And if we're facing something genuinely scary, we also have a body that is activated by stress hormones, etc. So we've got our already noisy bodies are made noisy by the stress of facing an imminent illness. And I think all of these processes add together to create sort of a kind of spiral into illness for some people. I mean, all of us have these experiences. When I thought I had COVID multiple times at the beginning of the pandemic and I never did, I eventually accepted that I never did. But for some people, they never get past that point, and the symptoms accumulate, and that can lead to disability. And that's a very common and easy thing to happen. It has no implications about who a person is or how intelligent or how insightful. I knew how to tell the difference between COVID and not COVID. It didn't protect me in any way from thinking I had it many, many times.
And you talk about how powerful this can be in terms of you going beyond an individual and going into groups, and the ways in which this can happen kind of across the world, across lots of different groups, and the similarities that there are between these kind of mass events, but things and the similarities which, from your perspective, mean that when you look at things, you talk about Havana syndrome, they very much fit into this group. I mean, what are the kinds of things that make you think, okay, this sounds like it's something that's psychosomatic, that hasn't been caused by a virus or a pathological process in that sense in the body?
Yeah, so I've talked to a lot of people who've been involved in mass hysteria outbreaks, and I should say not one of whom would say they were caught in a mass hysteria outbreak. That's not what it feels like when you're personally caught in it. But for example, children, well, it's not strictly mass hysteria, but it is this kind of socially spreading illness. Children in Sweden who were asylum seekers, who, when faced with deportation from Sweden, fell into this sort of very hard to explain coma. I have talked to people in Kazakhstan who, when faced with a particularly stressful kind of social situation and poverty, again, fell into a kind of a strange sleeping sickness. And as you mentioned, Havana syndrome, which affected American diplomats in the embassy in Cuba, who believed they were being attacked by a sonic weapon that produced a kind of array of symptoms like dizziness and tiredness. You know, these sort of outbreaks, they always have a very similar trajectory, which is that they start with quite a discrete concept. You know, I've been attacked by a sonic weapon and that's caused dizziness and hearing problems. And then usually the trajectory, as they spread, and they spread by word of mouth usually, and they begin expanding through the classification effect. So what you have is you've got somebody who believes they've got a particular disease that causes sleeping or hearing problems, and they believe it has a certain cause. And somebody else in the environment who perhaps isn't feeling well says, well, I'm not feeling well. Perhaps I have also been attacked by this weapon or affected by this poison, but I don't just have hearing problems. I also have palpitations. And it's really amazing how these sort of concepts spread so quickly and then continue expanding, because it can start with one symptom and every new person brings a new symptom to it. And their new symptom invites the next person, because now people with palpitations can consider, well, are they part of this poisoned group? Now you've got hearing loss, palpitations, and the new person says, well, I also have a headache. Now you've invited further new people into the group. So when you visit these groups, the trajectory of the symptoms are always really similar, which is that you start out with quite a simple set of symptoms, and then they just grow and grow, inviting new people all the time. So there's this sort of, the way these things spread is always very interesting. I also, usually they are quite biologically impossible, these disorders. So, that's they're based on kind of folk concepts about how the body works rather than the reality of how the body works. So if we talk about Havana syndrome with embassy officials, obviously very intelligent, very educated people, making that point, because I think that people tend to think you're weak or you're simple-minded in some way. These are very educated, well-traveled, intelligent people. But their understanding is that a sound weapon would affect your brain because sound goes in through the ears. Well, obviously, sound is just transmitted to the brain along a nerve the way any other sensory signal is transmitted to the brain. And sound doesn't have any particular preference for the brain. A loud sound, sort of a rush of energy, should affect any organ. So another feature, I think, of these disorders is this sort of biological kind of sort of impossibility of how people think it works. So it kind of makes sense on the surface. Oh yeah, we can all imagine sound going through our ear to our brain. Yeah, I see that in the first instance. But the minute you start thinking about it, well, you think, well, what about all these organs that aren't protected by my skull? What about, what does energy do to them? So they don't tend to make very sound biological sense, and they tend to have a very particular pattern of spreading, and with the symptoms just growing and growing, and the victimology changing as well. Sort of, it starts with affecting a discrete group, and then more and more people in different groups get affected. So I find that, the stories, I've talked to people in Kazakhstan who thought they were poisoned, or, people in from Nicaragua who believe that they're being affected by a spirit. And all of their stories are just so incredibly similar and have so much overlap, that I don't think these outbreaks are very hard to recognize. But if you're caught in the middle of one, I think then it's different. Looking from the outside, it's very, very easy to say, I think that's what's happening. But much like being caught in the COVID pandemic and not being able to tell one bodily change from another, and not being able to make sense of it, when you're in the thick of it, it's hard to spot. But the trajectory of these disorders tends to be very similar.
And they tend to be extensively investigated by the people who are in the thick of them, right?
Yeah. I mean, it's absolutely astonishing how long people, and this is a big issue for people with psychosomatic disorders in general, but it's absolutely astonishing how many medical tests will be done before people start thinking of alternative things. Often they never get to the thinking of alternative things stage. It's I met people in Kazakhstan who, in the context of extreme kind of social stressors, they began getting tired and falling asleep for apparently no reason. And some of those people that I met in Kazakhstan had like 9-10 brain scans. I mean, how many brain scans do you need before you kind of think, okay, the brain scan, the answer does not lie in the brain scan? And the other thing that happens is that scientists start getting more and more inventive. So if you take the group in Havana, who believed that they had been assaulted by a sonic weapon, the scientists involved in that case, they said, well, all these brain scans are normal. Oh, you know what? Let's just do more sensitive brain scans, fancier brain scans, So scientists are very sort of colluding on this, because they just start doing more and more sensitive scans. But what happens when you do more sensitive scans, as I'm sure you know, is that you start picking up little irregularities, and that drives the whole process forward. This is an issue for people with individuals with psychosomatic disorders. is that I think when they go to doctors with a sort of real concern that they have a particular disease like multiple sclerosis or whatever, that a doctor in the first instance, even though they strongly believe that that person doesn't have multiple sclerosis, we do a thing where we do scans to reassure people. First of all, I think that is a risky thing to do, because when we've only had MRI scanners since the 1990s in regular use. We're still figuring out all the little sort of scars and blips and things we have inside ourselves. We're only now learning the range of what normal looks like on the inside of us. So when you do a scan that a patient doesn't really need, you risk picking up something and not knowing what to make of it. But the other thing that happens to people with psychosomatic disorders is not just incidental findings on scans, it's the time wasted. So if somebody comes to us with, paralysis in their legs, a lot of people will do this scan and this lumbar puncture and then another scan and then some blood tests. And the nature of medicine is that takes a year to do, or that takes 2 years to do. It also causes a big buildup of anxiety while it's happening. And for a patient who turns out ultimately to have a psychosomatic disorder, that's harmful in 2 ways. Firstly, it's harmful because you've just allowed them to live with the disability for 2 years. And the longer that, a person is disabled, the more difficult it is to reverse it. And secondly, you've led them to believe that you think they have a disease. And now, because 2 years later, you didn't find anything on the scans, you've changed your mind and you think it's psychosomatic. So it's kind of it can mislead the patient into thinking you've made the diagnosis because the scans were normal, rather than you've made the diagnosis because you made a clinical judgment the first time you met them. So I think, sometimes as a doctor, it's very frightening to tell someone they have a psychosomatic disorder, because you do not want to be the doctor who tells someone they have a psychosomatic disorder and then they come back a year later and say, I had a brain tumor and, you missed it, etc. So we're all very, very frightened not to do the scan, and we're frightened to give this diagnosis. And I will still err, although I think tests can be harmful, I'll err on the side of doing them. But I think not enough doctors think about all of the harm done by delaying the functional or psychosomatic diagnosis. So yeah, listen, we love biology. We love doing tests and finding abnormal things on scans. And we've got so many tests to do now. I mean, you guys are very young, but when I qualified as a doctor, we only had, someone came to you with a neurological problem, you did some evoked potentials and a CT brain scan and a lumbar puncture, and then you'd sort of run out of things to do. Whereas now, you can send people for more scans and more scans. I fear that that's causing a delayed diagnosis. And certainly in these mass hysteria groups, it does nothing but cause harm, because they find incidental findings that necessitate more tests, and that's not good.
I'm really struck by what you describe in terms of having more and more tests available to us, because I guess in psychiatry we're in a position where we kind of don't, but we kind of try to, so it's becoming routine to, at least in the hospitals where we work, for people who come in with a first episode of a psychotic illness to have an MRI scan. We have sort of a whole concoction of blood tests that we will do once someone is first admitted to hospital, but even really that are in the guidelines to do, to kind of rule out other possible things that could be causing, someone to have intense anxiety, or that could be causing someone to have really low mood. And there is, I think, increasingly a recognition that they are more often than not normal, but we still do them and still search for them and kind of still yearn for access to them. So it's interesting to hear you talk about you working in a specialty where actually you do have access to lots of scans that can be, lots of tests that can be very helpful. But there's another side to that.
Yeah. I think that basically sometimes patients perceive that the better doctor is the one who does all the tests, because they come and see you with whatever symptom and you do the scan, which is kind of saying, I believe that you're suffering and I'm making a genuine effort to find the answer. It's so easy to do a scan, that's sort of, you see someone who's got a symptom and they want a scan, that's a 5-minute consultation. to see somebody who's suffering and you don't believe they need a scan, and you believe that you just need to explain their symptoms to them in a way that will help them to understand those symptoms, that is a very long consultation. So it's very easy to do a scan, and I think as doctors, we're also specialized now that it's also very easy to do a scan and then discharge people when it's normal. I report EEGs, and I think that I look at a lot of EEGs, brainwaves, and I think they're really a good example of how things can go so wrong for patients with tests, because our EEGs, our brainwaves, are different between individuals as our external appearances. We all have noses and eyes and heads, etc., but we don't look anything alike. Now, we see when you look at lots and lots of EEGs, you can look at two people who externally sort of are a similar age, etc., and you look at the brainwaves and they're completely different. They have similar elements, but they're not the same. The opportunity for a doctor to call a difference an abnormality is absolutely available multiple times per day. And the overdiagnosis that comes from that is phenomenal. A phenomenal number of EEGs, brainwaves, are reported as showing, you will see reports that say vague, hard to understand things like excess of slowing, indicating cerebral dysfunction. That's a meaningless statement. But to a clinician or a patient, getting that report back immediately says there's something biological that I need to pursue. So I think like EEGs, brain scans, etc., all of these tests, they have such a range of normal, and the cutoffs between normal and abnormal are so hard to define that I really advocate for making those cutoffs such that you are avoiding as many false positives as possible, which means you may sometimes have a false negative. But my point when I'm teaching students about tests is, let's say that you've got a patient who comes to you and I report the EEG and I underreport it. I say, maybe it's sitting on that borderline, and I say, listen, I'm going to call this normal. Whereas another doctor might call it abnormal. My point to the students is, if I call this test normal, the doctor who's looking after this patient, if this person is still having seizures, will not say, oh, fantastic news, your EEG is normal, go away. If the person is still having seizures, they will continue to see that person and continue to investigate them in other ways, or maybe do something else. On the other hand, if I see a test and it's sitting on the border between normal and abnormal, and I call it abnormal, it will be abnormal forever in that person's medical history. It will be interpreted as meaning they have a brain disease, and that will never, ever, ever be undone. So sort of erring on the side of a false negative, I think, is sometimes a bit safer, assuming the patient isn't discharged, assuming if they're suffering, someone continues to try and figure out why. Whereas false positives, they're very hard to eradicate from a person's, if you're told that your scan is abnormal, and then a doctor says, don't worry about it though, I think it's okay. I mean, how do you put that behind you? It's very, very difficult. Tests are a minefield, and I'd love for the general public to understand that a little better, so that when they get an abnormal test, they realize how gray it all is. And I'd love for doctors to think a little bit more about it before they do the test.
Because actually that uncertainty that again, I never remember being taught at medical school, but just slowly over the years of working, and I think particularly in A&E, the uncertainty that actually doctors work with, but also kind of impart upon patients. So for instance, when we give someone a diagnosis, what often doesn't get communicated is, I think, maybe, but maybe not, and come back if something changes, or likewise when we don't give a diagnosis. And also sometimes people, I think, do kind of stab in the dark, but people, and again, I think this is something that you talk about in the books, but, people take it as gospel. They're like, okay, someone's given me this. Like, what could we be doing better, either in training or in talking, or in how can we get that nuance across, that we don't know everything? We really don't know everything.
Patients actually appreciate it if you explain those thought processes. First of all, I think there's certain areas of medicine where, you can't sit around thinking thinking for ages. There are 2-week cancer waits for a reason, etc., and there are emergency situations. However, actually, in the vast majority of medical situations, you do actually have time. And I have a real compulsion as a person to think that I have to give definite answers, and I have to solve, if a patient mentions anything to me, I'm sure sometimes they're just telling me because they want to tell someone, but I have the immediate need. I need to solve their marital problems and solve their sort of employment problems. So we need to learn as doctors that, it's not necessarily what patients are coming to us for, is the need to immediately give the answer, know all the answers, and solve the problem. That some situations that's what they want, but not always. In a lot of medical situations, we have time to think. I see patients with seizures, for example, and it is perfectly okay for me in most situations to say, well, I'm not completely sure, and then explain these are the things that go for this diagnosis. These are the things that go for this diagnosis. Let's just see how this evolves. And if you have that conversation with the patient, they really appreciate it. They really, as long as you can communicate to them your reasoning for thinking different things, they understand that situation, and they appreciate the fact that you've clearly given it some thought, as opposed to just saying, I think it's this or I think it's that. So I think doctors need to be happy to take their time with the diagnosis and just explain to the patient why they're taking their time. It works better for us as doctors because I think it creates less mistakes. And it works for patients because they just want to feel like you have listened properly and that you are putting in some effort to understand their problem. So I think admitting your uncertainty, most patients actually appreciate that because it's honest and because it means they know that you're giving this issue some thought.
Yes, it's like the least healthy version of the patient-doctor dynamic is the patient who is seeking certainty and the doctor who is very eager to provide that certainty. And they can lock into a kind of dance that can be very dysfunctional. And I think as doctors, something I've come to appreciate more as I continue, I'm at the end of my training now, is the danger of the hubris. Because it takes a lot of hubris to be a doctor, to say, I'm going to be in charge of helping people with their disease states. And I think that's a dark side of medicine, whatever specialty you're in, we constantly have to be on the lookout for. And I think that's why the first thing mentioned in the Hippocratic Oath is first do no harm. Because although at a glance, being a doctor, you're just doing good things, no, actually there's a tremendous danger imbued in what we do, potentially the danger of unintended consequences.
Yeah, I think that you can get quite a lot of praise and admiration from a patient for taking a certain stance. And I often think that it's quite easy as a doctor to never get complaints or never have anyone tell you that you're a terrible doctor. And that's you agree with the patient about their version of events all the time. It can be the most difficult thing is to not agree with them, and that's one of the things that concerns me. But on the subject of hubris, yeah, I think that basically it's humility as a doctor to admit you don't know something is important, and that patients like that. They would much rather that you admitted that you didn't know something. Although one of the accusations I do get cast at me is not by my patients, I should add, but when I talk about psychosomatic disorders in public, not with the actual patients I meet, is that there's a misconception that saying something is psychosomatic is easier than saying you don't know. Actually, it's entirely the other way around. Saying you don't know, well, what can a person can't tell you, well, you do know, you're just not telling me, or, they're stuck with that as an answer. So I agree, if you don't know, say it. But I think some people perceive that compared to a psychosomatic diagnosis as an easy way out. I would say that the most difficult thing to do as a doctor is explain to someone that something is psychosomatic if that's not what they've come to you for. So yeah, there's so many traps to fall into with your own personality as a doctor, because I feel like we're not really properly trained to raise the difficult issues, that we're trained to be nice to people. And being nice to people is, I'm not saying we shouldn't be nice to people, but sometimes our being nice to people is such that we're afraid to say anything that will upset them in any way. And I think that sees a lot of psychosomatic disorders kind of poorly served, because we're avoiding saying the upsetting things so much that we don't tell people the absolute truth.
I think one of the most helpful concepts that I've been taught this year is compassion versus kindness, and this idea that compassion isn't, it's like you say, it's not this just being nicey nice and doing everything that will make the person feel fine, or compassion towards yourself even. You know, it's not just saying, no, I won't go for this run because I'm a bit tired. Compassion sometimes is saying, I am tired and it's going to be hard to go for this run, but actually I will feel much better if I do go for it. You know, and likewise, this is going to be a hard conversation with this patient, but actually it will be much better long term, and overall the kinder thing to do.
I think sometimes when we're in conversation with patients about psychosomatic disorder, so if you've gone to a neurologist because you're having seizures, or you've got paralysis in your legs, you know, something, you know, that is a clear physical disability, very few people go to a neurologist and think, now I'm going to be told that this is a problem arising, you know, from the mind or from something psychological. They're not expecting that. And because they're not expecting it or prepared for it or even aware that it exists, people will fight against that diagnosis. And quite rightly, in many, you know, I can understand their position, because they realize that if they accept this alternative diagnosis, they thought they had multiple sclerosis, but now they've got a psychosomatic disorder. They know that it'll be harder to get support from their workplace, harder to get support from social services, that they will have a 1.5 years wait for treatment instead of getting some instant treatment. So I totally understand why people resist the diagnosis. But the point was really that when a patient resists the diagnosis of psychosomatic disorder, they will often present, you know, some very good and strenuous arguments against it. You know, this is the reason you're wrong, doctor, and this is the reason you're wrong, doctor. And what can happen then in the sort of attempt to sort of, you know, not upset the patient or not disagree with the patient or give respect to their opinion, etc., is doctors can back down, I think, too much on, you know, we can feel really confident that we know what's wrong with them, and we can feel really confident that something is psychosomatic. But in the face of that argument put up by a patient who's in a very distressing situation, I think it's very easy for us to then kind of say, well, you know, I'm not right all the time. And I do say that always, I'm not right all the time, but then I will explain all the reasons I think I'm right on this occasion. But I think it's very easy with the doctor in our we're taught to sort of work with people and be nice to them. And I think that can make us back down too easily on very important issues, so we don't upset people in the moment. But sometimes the better thing to do is just be firm about your medical convictions and not feel the need to avoid upsetting somebody. This is an upsetting diagnosis for some people, and sometimes you have to drive it home, and you have to accept that their journey to accepting it will be an upsetting one. So I think, you know, as doctors, we're really not trained to do that. We're not trained to be disagreeable in any way, but sometimes not in a cruel way, but we have to be.
I wonder if, taking the example that you had with seizures and the way in which you might talk to someone when you're thinking about their seizure and convey some uncertainty at the beginning and take your time with that, I wonder if we could take that on a little bit of a journey and, you know, what might be a better way that we handle someone who, say, comes into A&E with a first collapse with some abnormal movements. What would be the things to say at that point? And then what might be the journey to try and avoid someone getting to you, I guess, 2 years down the line in a neurology clinic where you're bringing them in for overnight investigation, and at that point having to have a conversation that ends up being a bit like breaking bad news. What could that journey be like?
I mean, it's so important, because I feel like, you know, I now work in a hospital where I'm seeing people 10 years down the line, and it's very hard to undo functional disorders and psychosomatic disorders at that point. I used to work in an acute hospital where I was seeing people after the seizures, in the first week of their diagnosis, and you can cure people at that point. You can explain to them this is how the body works and cure people. So this is extremely important. I think that first of all, we need to just educate people about, it's very difficult to answer that question. You almost need an individual circumstance. So let's, in order to imagine, because it's different for everybody. So imagine that you've had, and this would be a very common scenario, you've got a young person on the underground and it's really hot and sticky. And in the context of that, they start getting dizzy and then they collapse and they have a few jerking movements. And somebody nearby has first aid training and they say, well, you had a seizure and you need to tell your doctor you had a seizure. And that person is kind of wakes up on the ground of the underground, surrounded by loads and loads of people. And they're rushed to the hospital and then they're told everything is okay. But then the next day they collapse again, and they collapse a few times and have multiple convulsions. And I've seen that particular scenario play out many, many times. So what we really need to do is to be able to explain to people that how the body works. In the first instance, explain to people that the first collapse is a faint because you're on the underground, and you can explain the physiology of that very easily. You're too hot and your blood pressure drops, and then when you fall, somebody catches you, so your blood pressure doesn't recover, and then you end up on the ground shaking, and that most people in faints shake. So you can explain the physiology of what's happening. Then you explain the sort of trajectory of that, which is that, our bodies are this kind of mess of noise waiting to be noticed if you're just given the reason to notice. So one day, someone in your family has a heart attack, and then you notice as you walk up the stairs, your heart rate goes up and you think, well, do I have a heart problem? Well, your heart rate went up every single time you walked up the stairs for the last 20 years, but you noticed it today because something frightening is happening in your family pertaining to hearts. The same thing for the collapsing on the tube. You had a moment of dizziness and it led to collapse. Now you've got to understand that, you're on the lookout for dizziness because something terrifying happened to you. You woke up surrounded by people you were rushed to hospital. It was a frightening experience. Now you're thinking, inevitably, because we all would, is it going to happen again? We all feel dizzy from time to time. The next time you felt dizzy, you had this kind of fear of the trajectory of what would happen next. And that's how these sort of things develop. And I think if you can explain to people that that's how the body works, that most people, even if they're sort of, I've seen this happen often, even if they're a little dubious about the explanation, they're thinking, oh, didn't feel that. I wasn't aware that I was searching my body for symptoms. I wasn't aware that that's what was happening. Merely explaining to people that this is a normal trajectory of how we think about our bodies and how we respond to symptoms. If we worry about a symptom and notice it, it can lead to the next symptom that we're worried about. Simply knowing that is enough to alleviate people, because it's the fear and avoidance that they've now caught in that you need to be able to sort of intervene on. You need to be able to just make them realize that, don't worry, just because this happened one time doesn't mean you're on a downhill trajectory to this happening lots and lots of times. And although you feel that something life-threatening is happening to you, it's actually okay. I think if you can have some coherent explanation for the physiology, even when a person is dubious that your answer isn't coherent enough for them, it works really effectively in preventing the next collapse.
How do you then handle it when people come to you further down the line?
I mean, it's incredibly difficult when someone sees you 10 years down the line, because you've so much to unravel, because it's very likely they've had 30 EEGs in that 10 years. And at least one of those EEGs said there was cerebral dysfunction in the left temporal lobe that could indicate epilepsy, because EEGs are so variable and it's so easy to report as abnormal. So there's a huge amount to unpick. I always go back to the very, very beginning first and try to understand, a little like mass hysteria outbreaks that kind of morph over time. I will often find that seizures, like dissociative seizures, have also morphed over time. As your expectations change, the seizures change. So the first seizure will have been a faint on the tube, and the next attack will be a very faint-like attack, and then you go to your doctor and the doctor starts going, did you smell anything funny before your seizure? That was never reported in your 10 previous attacks, but now you've been asked it so many times that you begin to think you do smell something funny. So I go back to the beginning and try and kind of understand what might have provoked the first one. Was it a faint that scared someone into having convulsions, or was it a psychological trauma that led to dissociation, that led to a seizure? Try to understand the very first thing that happened. And then you have to learn how to diffuse all of the iatric intervention that followed, which is the doctor who said that you had seizures based on this EEG. Well, I'm an expert in EEG, and I think that I explain all of the controversies and all of the uncertainties. I try to point out to them the pattern, and because very often there's a pattern that the more doctors they see and the more tablets they take and the more tests they have, they're not actually getting better. What's actually happening is that they're actually getting worse, or at very least staying exactly the same. So I try to say to patients, well, so you saw all of these doctors and all of these scans were done and all of these tablets were tried. Perhaps what we need now to do is try something just entirely different. What's the point in doing the same thing that everybody else has done? Can we entertain the possibility of trying to take a slightly different approach to this? Even if the diagnosis is difficult for a person to take on board, I think they can usually take on board that they're in a pattern that is not working and that a new pattern is needed. It's really also trying to make people understand the physiology, both of what's happening to their bodies is important, but also helping them to diffuse all of the misinformation that they have gathered from different places and all of their misunderstandings about the tests. But unfortunately, it's very difficult. If somebody's had dissociative seizures, for example, for 10 years, it is nigh on impossible to make them better. What you can do is stop them from having to go to hospital after every seizure and take them off all the toxic drugs and stop them seeing doctor after doctor after doctor. But after 10 years, you can't necessarily make people better. Sometimes all you can do is prevent them from being harmed by iatrogenic harms and help them be better supported in their lives to live better lives with their condition.
I wonder if I could take you back a little bit just on this idea that, when you go right back to the beginning, you're trying to understand what was happening at the time of that first event, be it for a seizure or I guess for another psychosomatic symptom. How do you, in your practice or in your thinking, deal with this idea that there isn't always a trauma, or there isn't always that there isn't always a trauma, which I think was what used to be thought much more?
Yeah. I mean, as a neurologist, I don't, first of all, I feel like we've moved. I just want to put in one slight disclaimer, which is I feel that, as neurologists, we've moved too far away from the concept that there often is a trauma. That particularly with the more severe disorders like seizures, where people are having lots and lots of seizures, there is quite often some extreme event in that person's life, perhaps in the distant past. I just want to make that point because I think, again, with the cleansing of the sort of word psychosomatic from medicine, I fear that, again, it's about not upsetting the patient or not looking directly at something that is painful to look at. We've started going a bit too far down the route of saying, there's no psychological trauma. This is a biological condition. So that is my disclaimer. But I think that basically what I say to patients is, first of all, I do try and figure out what's happened. And sometimes it's an injury. And because I'm a neurologist, not a psychiatrist, I don't take a forensic history of their childhood, but I will often, suggest to them things that in other people can sometimes provoke seizures and disabilities like these, and just present that as a possibility in case they wish to volunteer anything. But if I genuinely cannot find any particular provoking factor, be it an injury or be it a psychological trauma, usually I will say to patients, well, these things can be accumulation of lots of little things, that it's not necessarily a single thing has led to this moment. It may be so many little things that we can't necessarily put our finger on a particular cause. I will also remind patients, because I think it's a concern for patients if they don't understand the cause. It worries them. It adds to that feeling that you've missed something, you've got something wrong. And but I remind them that, in vast majority of my patients with epilepsy, and every patient with multiple sclerosis, we don't know why it happened to them. So it's not an unusual situation in medicine to find yourself in a situation where you don't fully know why something has happened to someone, but that doesn't mean you can't treat it. Just because we don't know why this has happened doesn't mean it can't be treated, because a disability, for example, like weakness in the legs or paralysis in the legs, that can still be retrained with a physiotherapist who's teaching you to use your movements normally again, and a psychologist who's teaching you to overcome the kind of psychological barriers of fear and anxiety, etc., that are preventing you from learning to walk again. You can treat all of these disorders without knowing what caused them. It is nice to know what caused them, as in the case of any medical symptom, and that's the ideal circumstance, but you don't need to know in order to make people better.
What are your thoughts on that search that we have in Western medicine for finding the cause, for finding the explanation for the symptom, and the aversion to just looking at distress or at social factors as being the reason?
I mean, yes, it was very much so I wrote 2 books really fundamentally about psychosomatic disorder. And my first book, first of all, I really recommend writing books about the thing you're interested in, because you just learn so much just by the process of having to interrogate your own ideas. But my first book was very much kind of, I was still in a slightly Freudian place of thinking that, everything, you needed to uncover traumas, and you needed to sort of understand the beginning. And I was a very kind of literal person, and extremely Western medical kind of trained in wanting to sort of make people confront their issues, etc., and wanting to sort of really bring everything into the conscious awareness was my desperate kind of need. And because I'm a doctor and I'm a logical kind of thinker, I like to understand things, so I thought you had to, for your patient, understand things in a very biological way in order to sort of help them. Then I went on the journey of my third book, but my second book, about psychosomatic disorders, where I visited lots of communities who had mass hysteria, and absolutely every single one of those communities would not agree that they had mass hysteria or that their problems were psychosomatic. And every one of them had their own internal explanation. Like, one community thought they were being poisoned, and another community that there was an evil spirit causing their illness, etc. And what was most interesting, what I learned from those communities, was that, first of all, they're not interested in my explanations of dissociation or my explanations about how the brain works. They had no interest in those explanations. But what was so startling was that they got better. Those people got better. And if you look at clinics where people are attending with severe psychosomatic disorders in a Western medical hospital, a huge number of those people do not get better. Recovery rates for serious functional disorders like dissociative seizures are only about 30%. But I was meeting communities just as disabled as that, and their recovery rates were like 100%. And I had to kind of ask myself, clearly we're doing something terribly wrong, and what is it? And what was clear within these communities is that they had a social problem, and that social problem was being sort of illustrated by the physical symptoms. So they were expressing their social problem as an illness, and by conceptualizing the problem in that way, they didn't have to do what Western medicine loves to do. They didn't have to say, I hate living in this town and I need to leave, but I'm finding it really difficult. Or this man is making me feel oppressed, and I want to do something about it, but I don't want to have to tell anyone. So they didn't have to talk about their problem, their uncomfortable things that they didn't want to face and talk about didn't have to be talked about because they were expressing them differently. They were expressing their distress as physical symptoms, which allowed them to escape those horrible conversations that we're all having. And their communities, because their communities kind of understood that these disorders are unconscious, and because they're blaming them on outside factors, came forward and supported those people, again, without needing to kind of be too frank or open about what might be the underlying problem. The symptoms asked for the help, and the community provided the help. And it was all done through metaphor, essentially. It was all done with, without anyone having to sort of really externalize the uncomfortable conversation. And then they responded to the symptoms by by listening to what the symptoms were asking for. The symptoms were saying, well, I'm living in a town where I'm being poisoned. Well, what's the solution then? Well, it would be to leave that town and get away from the poison. And I leave the town and I get away from the poison and I make a full recovery. And what's happened now is, through this kind of expression of distress as a physical symptom, is I've made the decision I was struggling to make. And I've made it without all of that sort of need to have that westernized sort of, if you admit that Freudian sort of moment of, oh, this is what's bothering me, and if I admit it to you, then I will feel better. They bypassed all of that, and they listened to what their symptoms were asking for, responded to them, and got better. I think that, our medicalization and both our biologizing symptoms makes them a permanent feature of a person. So if I say that my dissociative seizures are due to abnormal brain connections, well, that sounds like a pretty permanent thing. I'm not sure I can recover from that. Or the psychologizing of them, which is sort of forcing someone to face something that these symptoms are telling you they don't want to face, doesn't always work particularly well either. It's sometimes these communities taught me that just kind of treating the symptoms as metaphorical and not resisting them as a Western medical doctor and forcing them to use something into the consciousness that doesn't want to be there is a much more effective way of making people better. I should say, personally, as a doctor, I'm terrible at doing this, by the way. I want to be literal all the time, and I have difficulty working with the patient's formulation. But I think that's what neurologists, I'm sure psychologists already do this, but medical doctors such as neurologists are bad at it. We need to work with the person's formulation, figure out what they think will make them better, and within reason, see if we can work with that to make them better.
Mm. It's a concept that I think I'm finding hard to get my head around, because there's still a distress in I guess I'm thinking about like the mosquito communities, where often young women, and maybe if we have time, we can talk about young women a bit more, because it's something you mentioned at the start as well. But young women developing, I guess, in adolescence or late adolescence. Actually, maybe I'll hand over to you to explain what the kind of syndrome in the mosquito community was.
Yeah, so the mosquito people live on the Mosquito Coast of Nicaragua and Honduras, and they're the indigenous people of Nicaragua and Honduras. And they have what we call a sort of cultural idiom of distress, or culture-bound syndrome, that's called greasy sickness. So greasy sickness actually manifests kind of not dissimilarly to what we would see as dissociative seizures in a Western formulation. So in the context of very particular social stresses, and this would be, these are religious communities where young women are expected to be religious and dignified, etc., but they're also sexualized sometimes by older men. So they're caught in this sort of situation where, one thing is required of them, but they're also being treated in a way that is contradictory to that. And how do they deal with this male attention, whether it's wanted or unwanted? And in the context of those particular stresses, young women develop this thing called greasy sickness, which is basically frenetic. It begins with sort of, they see a hallucination, which is often personalized and related to the concern that they have. So they see the figure of a man, or something that is kind of sometimes relevant to the distress. So in the case of someone who assisted in an abortion, they saw a baby. So it begins with some sort of hallucination that probably has some relevance to the condition, and then they develop this sort of frenetic behavior, running, trying to escape, and that evolves into having convulsions. And this condition is considered by the people to be due to an evil spirit. So the mosquito people believe that it's caused by an evil spirit, and that the correct thing to do in this circumstance is to they restrain the young women, and then they treat them with traditional healing methods. And yes, when I first came across this condition, I had difficulty with it because it's so full of concepts that I don't subscribe to. First of all, I'm not a religious person, but I accept the religions that exist in the UK as people's beliefs, but I struggle with this concept of spirits coming out of the woods, etc. So kind of saw that in the first instance as superstition. And also I struggle with the concept that that the way the young women were treated when this happened, they were often pinned down and had these herbal potions thrown over them. But actually, as I learned more about the disorder, I realized it's actually kind of a phenomenally sophisticated kind of language of distress within these communities. That actually what these young women are doing is they're asking for help. And because this is a legitimized condition that is not seen to be stigmatized or the fault of an individual, it brings a very intense community response. So that young woman is immediately supported by all of the community. In direct contrast to what happens in the UK, if you've dissociative seizures, you're probably going to be stuck in your bedroom and no one will be paying you any attention. What this condition does is it brings the community to the support of the young woman, and that usually makes things better. Most of these young women just completely recover. So it's a kind of a sophisticated language of distress used within that community, where one person asks for help and the other people respond by giving the help, and that makes things better. Does it solve all of the underlying social problems? Clearly it does not, but it is a way for people who need help or feel in a trapped situation to get help.
And in what you were saying, the question that comes to my mind is how we think about it's an unconscious ask for help or an unconscious ask for attention. How do we contrast that with the more sort of pejorative, they're just attention seeking?
Well, that's the problem, isn't it, with all psychosomatic disorders, is that basically people are dismissed as you say, as just attention seeking. I mean, all we can really do, I think, is educate people on we're all, I say to everybody all the time that, we're all a mess of psychosomatic symptoms at all times. That is how our bodies and our minds that's how we work. You can tell that somebody is sad by looking at them. You don't have to ask them. You can tell if a person is confident or shy by looking at them. We communicate through our bodies, so this is essentially our fundamental physiology. And that in certain more extreme circumstances, those bodily communications could be more extreme, just doesn't seem that odd to me. And so I think we need to normalize this concept. I think that, people don't really think about how much they are using their bodies as their sort of expressions of communication. And essentially, all of our thoughts are embodied. And I think people don't think that, what's the first thing that happens if you feel fear? You don't feel it necessarily in your brain. You feel it in your stomach. You feel it in your chest. I think we need to normalize the concept of the kind of embodied emotions and embodied thoughts, and the fact that this is ubiquitous for us all, so that we can stop looking at these people who have the more extreme form of what we all have and realize that they are not doing anything that is any different than what we're doing. It's just they are more distressed, so they have needed a bigger expression of distress. The
phrase attention seeking also denigrates the idea of social attention as if it's not an incredibly important currency that we all need and crave, and everyone needs attention. It's very important for all human beings to thrive, is to get attention. So to say someone is merely attention seeking is really trivializing something that's important to everyone. I found what you mentioned about the is it the mesquite community?
Yeah, mosquito, yeah.
Mosquito community. That's so interesting, and it's really puts into sharp relief the position that women in most societies are in, that we're put, I guess the phrase that came to mind when I heard you describe it was double bind.
Mm.
It's a double bind that on one hand, young women are sexual objects,
Mm.
sexually objectified. On the other hand, women have a tremendous amount of pressure to be very discreet and careful, and they're idealized often as moral objects as well. And it's a very, very precarious position, particularly in that community, but really in most societies that young women find themselves in. And again, I'm thinking about Freud and Victorian times, where women that Freud saw were put in a similar position.
Mm. I think that, when you look at the groups of people who are affected sometimes by these disorders, I mean, many people will be aware now that in Iran, there's groups of schoolgirls having seizures en masse in schools. And that's being, again, as these things always are, it's being attributed to, malign forces, poisons, etc. But if you look at the videos of the seizures on the news and hear how these seizures, the trajectory of these seizures, they break out in big waves in schools, but it's just the school children who are affected. It's not the teachers, it's not other people. Could anything be more necessary? A group of people, they're going to school and no one wants them to go to school. Is there any group with less of a voice than that group? Women who want to be educated, but no one wants them to be educated, women who want voices, but they have no voices. When you look at these sort of extreme communities, similar, I met a community in South America where there was huge outbreaks of seizures in schools, again, in young women who were, in the context of these seizures, talked about in that, they need a husband, they need sex, they need less sex. That's the way we talk about young women. When you look at these communities where the sort of inequalities between men and women are more marked, it's easy to see how these things happen because, the differences between men's and women's lives in Iran is obviously huge. But I think it applies to us in London as well. I think we like to think that we've achieved, it's harder to see, but it still applies. We like to think we've achieved a certain kind of equality between men and women, but young women are still being judged more on their appearance than anything else. So is it a surprise that they express themselves through their bodies, since that's how they are being judged? And I think women are still having difficulty having their voices heard. It's harder for a woman to be strident and outspoken. It's less acceptable than it is for a man to be strident and outspoken. So I think you see it in sharp relief in the communities where there's a big difference between how men and women live. But I think it's still the case even in the most modern of societies that, women are more likely to find themselves in trapped situations. They're more likely to find themselves in situations where they feel they can't be heard. They're more likely to be judged on external things. And I think this creates a kind of melting pot for a need to express your distress in a way that is effective. And illness, physical illness, is sometimes an effective way of being heard.
And yet, I guess in our approach to it, we look then for a physical treatment as well. I think you speak about the children with resignation syndrome, so with these children who are asylum seekers, and the answer to their coma isn't a personal body one.
Yeah, these young people, as young as 7 and some older, some 16 or 17, enter these kind of intense, kind of prolonged sleeps that can last months or even years. So these are children who become apathetic, take to their beds, stop eating, talking, or moving, and essentially stay in that state sometimes for years. so much so that they have to be fed through NG tubes, nasogastric tubes. They have to be have physiotherapy from their parents to keep their muscles and their joints healthy. They wear nappies because they literally do nothing for years at a time. But I visited these young people and I found the conversation around them fascinating because all of these children went into this state. They came they were all asylum seekers. So they had fled somewhere for a reason. So presumably they or their family members had had trauma that caused them to flee to Sweden and then to seek asylum. And then they faced an asylum process in Sweden, which is Sweden's, is a very, very good country to go to as asylum seeker in general. Everywhere is becoming a bit more right wing, but it's a generally good place to go. They were treated well, but they had to go through a lengthy asylum process that saw them being rejected constantly and then ultimately told they had to leave. And it was the moment of having to leave that caused this sleeping sickness or resignation syndrome to happen. What was most fascinating to me when I went to visit those children is how little people talked about these social provokers of the illness. People were all aware that this was why they fell into resignation syndrome. But when I went to visit them, all of the questions I was being asked were, what do you think's happening in their brains? What kind of brain scan do you think will... It's obvious what the solution is. The solution is we need to have a different policy for asylum seekers. And the solution is we need to make these children feel safe so that this cascade of symptoms doesn't happen to them. But I think, we have a great deal of difficulty. Well, you know what? Social problems are hard to change, aren't they? If we could solve, we're trying, I suppose, as doctors, we know we can't solve the asylum situation, the immigration situation. We know we can't end wars in certain places. So what we do, instead of just kind of looking at them head on, we try and look at the things we think we can change, or we do the things we think we can do, such as brain scans, even though they're kind of a complete waste of time. It's so much easier to do brain scans than to admit to the social problems. It also, I think, for some people makes them feel that you're diminishing their suffering if you focus too much on the social side of it. It's sort of, it doesn't adequately acknowledge the amount of physical suffering or the amount of disability that's there. So I think there's a lot of reasons why it's easier to do brain scans and to give drugs and to talk about brain mechanisms than to talk about the social problems we have in the world.
And again, it's one of those situations where that nuance of, whilst being granted sort of permanent residence in the country would be the cure, and has been the cure for some of these children, they're still not choosing to be unwell.
Yeah. I mean, yes, I think people just, people have a real comfort with, we all understand that the little ways in which our body responds to kind of stressful things. We can all feel that heart racing thing or that sort of hands shaking thing. But the minute you're faced with a severe disability, a lot of people can't make that extra move. They think that psychosomatic symptoms are things that you can associate the emotions happening at the time. So you should feel, if your symptom is psychosomatic, you should feel anxious. And if you don't feel anxious, it can't be psychosomatic. And they also can't believe that severe symptoms have a psychological cause. So we can accept the mild symptoms, but not the severe symptoms. I think, what people need to understand is that these problems are cumulative and are often severe, by which I mean that you get one symptom and you have this looping effect that leads to another symptom and another symptom and another symptom. So severity is actually quite a common process, and chronicity is very common in these disorders. And I think if people understood that, I think they look at the sleeping children in Sweden have often been accused of faking their illness. Maybe not deliberately the children, but perhaps the parents persuading them or the parents drugging them. And of course, somebody at some point told a newspaper that they had been told by their parents to fake it. You know what? There's lots of people out there faking back pain, and there's people pretending they were in the Twin Towers when the Twin Towers came down. And there are people who take advantage of situations for their own gain, but there's no evidence whatsoever that the sleeping children were doing anything other than suffering unconsciously. I think we need to educate people to this mind-body connection and how severe it can be for people to just, why do we have to keep answering that question? It's never the most important question. Do you know, I feel a little bit about the sleeping children also is, who cares if they're faking it? I feel a little bit, the point is they have an expression of distress because they're in an extreme situation. Why do we care how purposeful it is? If a child is immobile for months or weeks or years or even days, then that is saying something to us, and we need to listen and worry less about both the question of is it real or isn't it, and also what's happening in their brains.
So you say there are always people who might take advantage of a situation, but is this common? Is this a big problem in your work?
Absolutely not, is what I would say. I would say that, of the patients, so I see lots and lots of people with functional disorders, in particular seizures. And I would say the number of people I see who are malingerers, so malingering being pretending to be sick in order for some sort of gain, usually financial gain. So malingering and pretending to be sick for some sort of personal gain, particularly financial, is not an illness. It is obviously just an illegal activity, as opposed to functional disorders, which are clearly entirely unconsciously generated. I think I almost never see malingerers. It used to be a concern, and probably again when I was a junior doctor, these are things that worry us that I think should not worry us. I think malingering is extremely rare, and in the specialist services, it doesn't, by the time you get to a neurologist, you almost certainly have a functional disorder. I think malingerers is usually quite easy to spot because the malingerers are the people who don't want tests. If you're pretending to be sick, you're pretending to have seizures in order to sue somebody or have some financial gain. The exact last thing you want is to be in a video telemetry unit having your seizures videoed. That you're pretending, and that's really, the performance anxiety of that, and realizing you're in a specialist center is not what you want. So if I ever suspect, which is very rarely, that a patient of mine is malingering, it is usually because, when I offer them the sort of intervention or the tests, they just keep refusing it for some reason or other reason. Doesn't happen very often, but I think more than anything, the patients are desperate for answers, and that is evidenced in their desperation to see the doctor, to see the specialist, to have the test, etc. So I think that malingering, doctors should not concern themselves with it. First of all, you never ever want to be in a position of accusing your patient of malingering, because that really is the most sort of insulting thing that you can do to a person with an unconsciously generated problem. But secondly, allow it to reveal itself, and it will very rarely do so because it's unusual, I think.
Mm. And we've spoken a lot about the way in which psychosomatic symptoms can come up through brain type things or your neurological function, and obviously that's where you work. But they're common kind of in all other parts of medicine as well, but maybe are a bit harder to pick up, or I don't know if harder to pick up is the right word, but people don't necessarily get a functional diagnosis in the same way. Why? What?
Yeah, the reason it's so topical and so talked about and now intensively studied, etc., in neurology is because we're a slightly more fortunate specialty in that we can, that the nervous system is arranged in a very particular way, which allows us to distinguish between a paralysis that is functional and a paralysis that has an organic cause. And also with seizures, we can measure the brain waves and tell the difference between someone who is functionally unconscious and has a brain disease causing them to be unconscious. So we've got a very measurable system to work with. But of course, we don't see more people with psychosomatic disorders than any other specialty. They're equally common in every other specialty. So, a respiratory physician will see people with the perception of being short of breath, chest pains, palpitations, stomach pains. The difference, I think, is that I think the frequency in other specialties is equal to neurology, but it's much harder in the concept of when you're dealing with a concept like pain to distinguish between, the pain of an underlying biological inflammatory condition and the pain that might be arising from a functional or psychosomatic disorder. And I think it makes, so the very common, every single specialist deals with psychosomatic disorders. The dermatologists see flitting skin rashes all the time and often work with psychologists. There's a lot of psychodermatology clinics now. So every single specialist will see this represented in their practice. I think the difference is that whether you are dealing with a symptom which is easily measurable and therefore distinguishable, one type of this from another type of this, it's harder to meet it head on. If you're working with pain, for example, it may be difficult to say where the pain is coming from exactly. What I would say, though, in those circumstances, what I say to my patients is, okay, we've done all of these tests and we don't 100% know, which is not something that is unusual in medicine. We've been willing to explore with scans, and we've been willing to explore with physiotherapy, and we've been willing to explore. Why don't we now just explore, I've ruled out serious diseases. Why don't we just now explore this other option and think about dealing with this as more of a psychosomatic problem? But yes, these problems are equally prevalent in every medical practice, but just harder to identify with absolute confidence in symptoms that aren't easily measurable.
There's something really there's a really important psychological understanding implicit in everything you've talked about with regard to psychosomatic illness. And I think this is an understanding that really anyone can benefit from. I think that understanding is that we have these perceptual systems, all the sensory inputs we get, sight, sound, internal bodily sensations. And these systems are filtering information out, discarding 99% of the information that they could pick up and focusing on a particular 1%, say. And that focus, what's excluded or included in that, is usually determined by our state of mind. And that could be a belief or a suspicion in the case of psychosomatic illness, or a mood. And for example, if you're in a bad mood, you tend to look for evidence unconsciously to perpetuate your bad mood. You think your partner's cheating on you, you overemphasize information that you might not normally pick up on. If you think you might have a disease, your internal bodily sensations will focus in on sensations which might confirm that hypothesis. If you're looking to buy a Toyota, we walk down the street, all you see are Toyotas. And this understanding is one thing I really want everyone to know, because it allows someone to be much more flexible in how they use their psychology to get out of a bad mood, or to realize that they can fall into these traps, or even just to make their life more better in an active sense.
I think what the problem is that a lot of people think they have much more control over their bodies than they actually do. I think that we think that, especially if we're alert and paying attention and intelligent and thoughtful and trying our hardest, we think that means that, we are actually controlling all of those sensory inputs and all of that motor activity. But actually, I always kind of give the example of, say, if you write a book or you write your PhD thesis or anything of any sort of length, you can be intelligent, focused, careful, detail orientated, and you will read over that typing error, that humongous typing error, like 100 times, until fresh eyes come to it, and then they see the typing error. And that's because basically when we're looking at a page of text, we're seeing what we believe to be there, even more than we're seeing the thing that is actually there. And that is how our brains work. Because if our brains didn't work that way, then every time we saw a new type of handwriting, or every time we were sent a text full of kind of predictive errors and misspelled words, we wouldn't be able to read it. We would have to go back to first principles and say, how does the world work? So our brains, in order to make sense of this world where we're seeing objects from different angles, and we haven't seen every example of a car in the world, but that doesn't mean if we see a brand new car that is a completely different shape to every other car we've seen before, that we cannot recognize it, because we're constantly manipulating the things we see and comparing them to things that are stored in our brain that as priors or templates that tell us this is what the world looks like. This is what cars look like generally. So now go out there and recognize every car. So we are not seeing the world literally as it is. We are taking in the sensory signals, and we are at the same time manipulating those sensory signals to make sense of them according to our experience. And that works brilliantly, 99.9999% of the time. Probably less than that, actually, because we miss typing errors all the time. But, it works to keep us safe. It stops us getting knocked down. It means we don't have to relearn things every day. But it also means that our sensory systems are not reliable no matter how hard we're trying. And our motor functions are exactly the same, or, how we experience the sensory world. The difference between somebody you like touching you and somebody you don't like touching you is a world of difference. Those sensations do not feel the same. So our sensory world is changed entirely by our expectations and by our beliefs, but our motor function is also changed by very little provocation. So how you walk on the street is very different to how you walk on a cliff path, where if you suddenly, misstep, you'll fall over. How a person kicks a football not in front of a crowd is completely different to how a person kicks a football in front of a crowd. Because we're changed by the attention that we're paying to our movements, and movements stop being automatic. And I think that people need to know that all of these things are important to keep us safe and to allow us to function normally. But like everything else in the body, they go wrong. And I think if people understand that that's just how the brain works, and it's a normal function of physiology, it might make it a little bit easier for them to understand when suddenly one day they've got an intense sort of sensitivity in their arm when everything touches them. It's not actually a million miles away from what is essentially normal. Or if they suddenly realize that, the coordination of walking isn't working very well, and they know that coordination is easily disrupted by paying too much attention to it, then they will be able to understand this is physiology. It doesn't mean that I'm not trying, or it doesn't mean that I'm going mad.
You end, I think, your third book with, well, I think first and third with calls to action. But in your third book, you sort of have this idea of how can we be more holistic in our view of health and in our practice of it. And I wonder if there are any changes or any ways in which you practice, or ways that you found to move towards this in your practice, in your hospitals, in the NHS, in a system that is very set.
Yeah, I mean, I don't think personally I have found any change within the system in which I'm working. But if, let's say, within my individual job, but what I would say is that two things. First, outside of the NHS, in society, we need to have better support systems. It does feel like, in Western society, the place that you can go for help is to your doctor. And I'm not a religious person, but, it used to be that you could go to your religious community, or, there used to be a greater range of support networks. And we're also very individualistic. We put our parents into care homes, and we kind of move out and live on our own. We have very individualistic society where we're less dependent on family, but therefore they're less available to us for support. So I think in society, what we need to do is have better support networks for people, so that they don't have the same need to express their distress in this physical way, that there's more help available that doesn't require things to get to that stage. So I would like to see society provide better support for people. I think that within the NHS, or not NHS, within any medical system, I think we do need to have more integration between the kind of psychological and psychiatric services and physical medicine. I know we talk a lot now about, the mind and body, mind and brain aren't separate things. Don't be dualistic, etc. But look at how we practice. I mean, you're in a hospital in the Maudsley, and you're in a completely geographically separate location to the place where the patients who have the physical complaints are. So I think we do a great lip service to this sort of, we're not dualistic anymore. But I would suggest that our practices suggest that we are. I'm obviously now very interested in the more kind of psychological side of things, but I've had no training, no training of that. How could a neurologist who works with the brain, and this is the case, I think, for most neurologists, how could we get through all of that training? And the most we ever got was like a couple of sitting in a couple of psychiatry clinics. So I really like to see there to be a psychologist involved in every medical team. And I would like to see every medical specialist have to get some training in the kind of psychological side of processes, because I think we talk a good game when it comes to saying, oh yes, mind and brain, these are all part of the same processes, but there's very little evidence of that in our practice.
I mean, I'd love the same vice versa as well, because I think for psychiatrists to have the fact that we in the UK don't have neurological training, and people will disagree with me on this, which is fair enough. There are, again, it's a nuanced issue, but it seems hard to see how some training and some broadening of the base of knowledge that we have couldn't be helpful.
Yeah. I also feel a little bit like it's been, when I trained in Ireland, and it's a small country, so you can't have a very, very wide number of specialists. You can have 10 specialists for headache and 10 specialists for, so everyone was a bit more generally trained at the time. But also with the way society has changed, we've all become so specialized. Like I'm an epilepsy doctor, don't ask me anything about peripheral nerves, because that was like 10 years ago or whatever. That's brilliant, because it's impossible for a doctor to know everything about everything. So I think it's, you do want to see a specialist doctor, because they have at least a hope of knowing the minutiae and understanding your condition. But I think we've lost so much of our ability to be general also, that we're doing a disservice to patients. If someone comes to me with seizures, they have a lot of other red flags of psychosomatic tendencies, psychosomatic disorders. They're also seeing a respiratory physician and a dermatologist and a gynecologist and, several other doctors. We're so specialized now. We're not very good at drawing all, what are the chances this 20-year-old has 10 completely unrelated disorders? It's more likely this 20-year-old has 10 symptoms that all indicate a single disorder. So I think I'd also quite like to see us retain our ability to be very specialized, but still have a better grounding in being more generalists, so we can kind of draw the symptoms together and have the person as a whole person, and not see them just as a brain and a bowel and a heart, etc.
Dr. O'Sullivan, I wonder if there's anything of the thrusts of your book that you want to make sure that we haven't missed before we say goodbye, or if we've been thorough, if you could give us an idea of what the future is like for you in terms of the things that you're maybe looking to write about down the line, or where you're at now.
If there was one thing that I would say that I haven't said, it is, I think, and I was thinking about this morning for some reason, I think traditionally the kind of patients I'm talking about here now with psychosomatic disorders, especially those with 10 different sets of symptoms, etc., they are often referred to, and you read about them in newspapers, etc., or in some publications, as heart sink patients. And what I would love doctors to realize is that this area of psychosomatic medicine is an area in which doctors can make people better with pure good doctoring. And there's very few areas where you can sort of see a patient who's got severe physical symptoms and are very distressed, and that you as a doctor can sit down and just have a really great conversation with that person, and that they can walk out the door and their symptoms are immediately alleviated. So if I wanted to say anything, because I think we approach these patients as if they're kind of a nuisance or hard to make better or not interesting, and also not rewarding. And I would say that there's absolutely nothing in the world as rewarding as seeing someone who's having 10 seizures a day, having a really great conversation with them, and then you see them a week later and you realize that just through the power of that conversation, their seizures have gone away. So I would like ultimately to present this disorder to junior doctors as something incredibly rewarding. These are not heart sink patients, and these are patients that, you actually can make better by being a good physician, and nothing feels better than that.
Dr. O'Sullivan, thank you so much for sharing your time and expertise and wisdom and everything. It's been really illuminating. I'm really grateful to you.
Okay, thanks for having me. Much appreciated.
You are listening to the Thinking Mind podcast. Thank you so much for listening to this episode. If you enjoyed it, please share it with a friend or give us a rating. It really does help people to find us. However, before I sign off completely, I just wanted to amend something from about half an hour into the show. I think what I said about the use of tests in investigating specific physical causes for things like psychosis, anxiety, low mood, for instance, MRI scans that look for structural abnormalities or abnormal thyroid vitamin levels, I think the way that I talked about it risks glossing over the very important role that these tests do have. So I hope what the discussion with Dr. O'Sullivan does is help us to think about these tests in terms of the risk and benefit ratio of them, not to forget the risk part, but also not to forget the benefits. But otherwise, thank you again so much for listening. If you value the show, you can buy us a coffee to help keep us going, and there's a link for that in the show notes. And as always, we're always grateful to receive your feedback, so drop us a line or get in touch on social media.